بسم الله الرحمن الرحيم. أنا الدكتور أحمد شوقي، أستاذ مساعد القلب في جامعة عين شمس. والنهاردة هنتكلم على complications of an acute myocardial infarction. Complications are one of the most important causes of mortality in an acute coronary syndrome. The frequency and the extent is not seen in all cases. It varies حسب severity of ischemia, حسب site of infarction, and the affected arteries, which is really important. Only structural and major mechanical complications are seen in huge ST elevation, or they were called before transmural myocardial infarctions. Like in arrhythmogenics, they can be caused in any type of an acute coronary syndrome. We can classify complications into electrical complications, mechanical complications, the incidence of heart failure, the inflammation of the pericardium or pericarditis, or recurrence of the ischemia, or as we call it, post-infarction angina, or even a reinfarction itself. Electrical complications are extremely important, and as said in the late management of patients with an acute coronary syndrome, these are the causes of death in the first 24 hours, usually arrhythmogenic. Ventricular premature beats are not so important as ventricular fibrillation, and these are usually treated as if we see any problems with the electrolytes or metabolic disturbances, but these are not as so important as others. An accelerated idioventricular rhythm occurs in 20 patients. This is something we see a lot after perfusion or reperfusion of the occluded artery, and this is rather good to see this idioventricular rhythm. It is an arrhythmia. It is a good arrhythmia. Then we go to the more complex or more dangerous ventricular tachycardia. It could be non-sustained when it occurs in short bouts, or it could be sustained with hemodynamic instability, and this requires immediate cardioversion, whether pharmacologically or by a DC shock, because this can lead to death. Ventricular fibrillation is the #1 killer. It could be primary, secondary, or even very late, and here the treatment is unsynchronized direct current shock. This is very important because this is the #1 killer of patients with an acute coronary syndrome, and this is an extremely important thing that can occur, as we said, early on and late, and that is why patients with an acute coronary syndrome should always be on a monitor that can be monitored by the nurses in the CCU. Supraventricular arrhythmias, common but less dangerous, like the sinus tachycardia, which is very common in myocardial infarction, whether it's an acute ST elevation MI or an unstable angina, because of the anxiety, the pain, the LV dysfunction, maybe some fever that occurs with the myocardial damage, but this is not something to be worried about a lot. Premature atrial beats also can occur due to so many causes, like the atrial ischemia or the pericarditis. Paroxysmal or supraventricular tachycardia, transient, and here one of the best drugs to manage is adenosine. Verapamil if the patient does not have an impaired left ventricular function, systolic function, or sometimes without pharmacology we can use a carotid massage to induce sinus rhythm. One of the commonest arrhythmias in all the cardiovascular disease is atrial fibrillation. It can occur in acute infarction, it can occur by itself, it can occur in so many other diseases, or by itself, as we call it, the lone AF. Usually it is occurring with patients with LV dysfunction, but here the only big problem is the anticoagulation that we should require. If this patient requires anticoagulation, this is according to the risk stratification of the patient, because not only is he going to take oral anticoagulation, he is also on dual antiplatelet therapy, which are the aspirin and P2Y12 inhibitors. And this is really important because this carries a high risk of bleeding. Not only do patients have tachycardia. They can have bradyarrhythmias like sinus bradycardia, common in right coronary occlusions in inferior and posterior infarctions. This can be more evident if we have a first-degree block, especially in right coronary infarctions or inferior wall infarctions, or if we use beta blockers or calcium antagonists. This can be augmented even further, secondary heart block, whether type 1 or type 2, or even complete AV block. And this is very common, or not so uncommon, with inferior infarctions. And sometimes it takes a long time to resolve. Not only after treatment, sometimes it takes more than a week or two until it completely resolves. Here, if the patient is in bradycardia and his blood pressure is going down, here pacing of the left of the ventricle is really important, so the patient will not be shocked and hypotensive. Mechanical complications include so many. We can have rupture of the free wall, thus leading to pericardial effusion and tamponade, pseudoaneurysm. Rupture of the papillary muscle can cause an acute mitral regurgitation. Rupture of the intraventricular septum can cause an acute ventricular septal defect. And these are very serious complications, not so common, but very serious. The papillary muscle, we know the mitral leaflets consist of two leaflets, and there are two papillary muscle, an anterolateral and a posteromedial. And they get dual blood supply from the right coronary, the LAD, and sometimes some septals from the circumflex, which is not so common. But rupture of a papillary muscle can lead to an acute MR, which sometimes can be heard as a systolic murmur, and you can have a giant V wave on the pulmonary capillary wedge tracing, again what represents the left atrial pressures. An echo or an echo Doppler will show this rupture or ischemia. Treatment here is very important with vasodilators to decrease the afterload, because the patient will enter immediately into an acute pulmonary edema which could kill him. And sometimes supporting the circulation with the forward flow is sometimes needed by more support, as we use sometimes an intra-aortic balloon pump. Sometimes this rupture can be seen causing severe mitral regurg with a flail mitral leaflet. That is to say, the mitral leaflet is way in the left atrium, causing an eccentric jet of mitral regurg, as we can see in this echo Doppler finding, and this color flow map of the left atrium causing severe mitral regurgitation. The acute rise of pressure in the left atrium causes sudden pulmonary edema, not like in cases with chronic mitral stenosis, chronic mitral regurgitation. Usually the pulmonary circulation is well acquainted with these high pressures. So we should understand that a normal pressure, and then it goes into a large V wave. If we have intra pulmonary capillary wedge tracing, this usually means that we have a very significant mitral regurg, usually an acute mitral regurg, not so common. The treatment here is very important by rapid diagnosis, afterload reduction, as we said, support of the circulation, increasing the blood pressure, like an intra-aortic balloon pump or intravenous drugs, and if it's a rupture, surgical valve replacement. In certain cases we don't. In acute ventricular septal defect, it can occur with either an anterior commoner or an inferior myocardial infarction. And the peak here occurs on the third day to the first week, and it causes an abrupt flow from the left ventricle, a high pressure volume chamber, to a lower pressure volume chamber, which is the right ventricle. Sometimes you hear it, sometimes you don't, but sometimes there is a systolic murmur heard of the parasternal area, and if we measure the oxygen levels in the right system of the heart, we see an increase in the right ventricle of the oxygen levels. How can this occur? Unless you have something shunting the blood from the left ventricle to the right ventricle. Here is a color flow, or an echo Doppler color flow map, showing shunting of blood from the left ventricle to the right ventricle, and here of course the right ventricle is dilated, and this is an acute ventricular septal defect of a patient with an acute infarction. So how to manage? Of course, again, rapid diagnosis. These patients enter into cardiogenic shock very rapidly. You find the patient that has improved after reperfusion therapy, and again, they have a big problem that occurs with cardiogenic shock. Rapid diagnosis is very important. It's not the index echo. Sometimes you have to do another echo, and of course you have to auscultate your patients and check them regularly. Again, after load reduction, intravenous inotropes, intra-aortic balloon pump, and repair of this ruptured septum is crucial. Of course, nowadays we can do this repair without surgery. Sometimes we put devices that close this defect, which are umbrella shaped. The intra-aortic balloon pump, this supports the circulation and improves the blood pressure, thus reducing myocardial ischemia by both mechanisms of decreasing the afterload, augmenting the blood flow of the coronaries during diastole. And we use them a lot of the times in cardiogenic shock and in patients that are going to undergo coronary artery bypass grafting or severe surgical disease patients that are under support. And it is put in the descending aorta, thus augmenting the coronary blood supply. Free wall rupture is either a cardiac tamponade with complete rupture into the pericardium, and this causes equalization of the diastolic pressures, hypertension, a distended JVP with usually pulmonary venous congestion and a pulsus paradoxus, or a pseudoaneurysm, which is consisting of an aneurysm with compressed tissue. And it's very important because it causes an enlarged cardiac silhouette on X-ray, and it causes a lot of problems because it's prone to rupture, and echocardiographic diagnosis here is very important. A true aneurysm can also occur in the apex, especially in the acute anterior wall infarction. And the apical aneurysm is really important because it can occur in a lot of patients, and this part of the left ventricular apex is not well seen by the echo, and it can lead to an LV apical thrombus. This thrombus can embolize to the brain or to any parts in your body. It also is associated with a lot of arrhythmias, especially ventricular fibrillation and tachycardia. And this aneurysm is really important to assess because sometimes you need anticoagulation to avoid the embolism that can occur from the thrombus. Pericardial inflammation or pericarditis, we can see this. There's stitching chest pain or pleuritic chest pain. It can be pericarditis by itself. It can be pleuropericarditis with sometimes a fever. A friction rub can be heard, and radiation to the trapezius ridge in the back. Shock, which is not uncommon, especially if you have a large area of myocardial necrosis. Mechanical complications like the ones we said with an acute mitral regurg or a ventricular septal defect. We have to exclude correctable causes. Other causes like hypovolemia, right ventricular infarction, and here again the intra-aortic balloon inotropic support are important until we do some sort of revascularization to save the patient. So in summary, complications of myocardial infarction are many. We have the electrical instability, which is the #1 cause of death in the first 24 hours, like ventricular tachycardia and ventricular fibrillation especially. We have the tissue necrosis causing papillary muscle problems, which can occur leading to mitral regurgitation, or the ventricular wall rupture leading to a cardiac tamponade. We have impaired contractility, which can lead to a shock, an aneurysm leading to a ventricular thrombus, and a stroke, which are very important. And we have the less commoner, like the pericardial inflammation, or the less serious, like the pericardial inflammation, that can lead to pericarditis. And thank you.